Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is an interesting case of a uterine mesenchymal tumor, uterine tumor resembling ovarian six-cord tumor. So this is a case of a 29-year-old female patient who presented with recurrent heavy periods necessitating blood transfusion on more than one occasion. So she was on investigation, was found to have a uterine mass that was thought of to be a fibroid. And this is the low power magnification of the edge of the mass. And as you can see, perhaps here, most of it is circumscribed. However, here there is a limited amount of infiltration into the adjacent smooth muscle fibers or myometrium. And on higher power magnifications, the cells are growing in sheets with some acidophilic cytoplasm. And here really gives some resemblance to stromal sarcoma tumors. The tumor cells are growing in sheets. They have oval nuclei, inconspicuous nucleoli, acidophilic cytoplasm. Sometimes I'll be showing you now, even giving this resemblance to rhabdoid tumors. No really easily identifiable mitotic figures or evidence of necrosis. And again, another high power magnification where you can see the sheet growth pattern, some tendency here at nesting, at nest formation, and here as well. However, pleomorphism is minimal, no mitosis, no necrosis. And in this area, really, the tumor cells tend to grow around the blood vessels, again, some resemblance to endometrial stromal sarcomas. So the differential diagnosis would include smooth muscle tumors, low-grade stromal sarcomas, or other types of tumors. And the first immunohistochemical stain that was performed in Heaven, and in Heaven is positive in the tumor cell cytoplasm as well as calretinine. And both of these markers are excellent clues that we're dealing with a tumor showing some sort of six-cord differentiation. WT1 is also positive, beautifully positive, showing this nuclear stain in the presence of the internal negative control. Remember that you have always to evaluate the positive immunohistochemistry in the presence of negative internal control and vice versa. So if we have something, an immunohistochemistry, that we should be looking for loss of the nuclear stain, for example, we should always make sure that there is positive internal control. So the tumor cells were also positive for WT1, again in support of some sort of six-cord differentiation. Cytokeratin, MNF, was positive in some of the tumor cell cytoplasm, as was CAM5.2, strongly diffusely positive in the tumor cell cytoplasm. ER was also positive. So as you can see, the tumor is showing more than one lineage of differentiation. Smooth muscle actin was also positive in the tumor cell cytoplasm, as was desmon. So we have an evidence of six-cord differentiation, perhaps some epithelial differentiation, and with desmon and smooth muscle actin, some sort of a smooth muscle differentiation. And certainly because of the morphology and because of the immunophenotypic features of the tumor, atypical teratoid rhabdoid tumor or rhabdoid tumor in general, they should be ruled out. Now, CD10 was focally positive in some of the tumor cells, not really diffusely positive, and this tends to rule out the differential diagnosis of stromal sarcoma. And INI1 was retained, showed retained the nuclear staining, thus ruling out rhabdoid tumor from the differential, from the list of the differential diagnosis. So given the morphology, the immunohistochemical features. The diagnosis of this case was uterine tumor resembling ovarian 6-4 tumor. It's a rare tumor that should be in the differential diagnosis whenever we look at, in particular, stromal sarcoma, and if we identify some acidophilic cytoplasm, sometimes even a clear cytoplasm, minimal nuclear atypia, usually well circumscribed, but might show some evidence of infiltration to the edge of the tumor. The possibility of this rare entity should come into the differential diagnosis, and it's usually easily settled against the other differential diagnosis because of the immunohistochemical profile, where the tumor, as I mentioned, shows this polyphenotypic characteristic with the different lineage of differentiation along the 6-4 stromal tumors, similar to the ovarian tumors, along the smooth muscle, and along epithelial differentiation. Of course, because of the low-grade appearance of the tumor, the possibility, and the endometrium was unremarkable, possibility of carcinosarcoma is completely ruled out. This tumor usually behaves in a benign fashion. Sometimes it has been there, some case reports with recurrence or even distant metastasis, but usually this is associated really with excellent outcome. And more recently, a translocation has been described that is characteristic of this group of tumors. I hope you find this tip useful in your daily practice. Thank you.